get started, you're very welcome to.
Okay, thanks very much. So welcome everybody on behalf of the SWOG Thoracic Committee. Thank you all for coming. We've got a good number of people signed in, and I think people will be signing in over the next few minutes. So the purpose of this webinar over the next hour is to discuss 3 of our ongoing SWOG trials, all of which incorporate radiation into the treatment of non-small cell lung cancer or small cell lung cancer. The goal really is to have the principal investigators discuss the essential elements of the trial. There'll be time for some Q&A to hopefully address any perceived barriers. I want to stress that the audience here are the I would say the customers of this trial. So we really do take your comments seriously, and we're happy to discuss anything you want to about it. So I'm joined today. We're going to have 4 speakers. The first is my colleague, Sarah Goldberg. Sarah is an associate professor at Yale with me, and she's going to give a little introduction to kind of give a little context for the background of these studies. We're then going to have our 3 PIs talk. Chad Rusthoven is an associate professor of radiation oncology at University of Colorado and is the PI of the 1827. Rod Al-Jamali is an associate professor of medical oncology at the Stevenson Cancer Center in Oklahoma, and he's the PI of the 1933. And Megan Daly is an associate professor of radiation oncology at UC Davis, and she's the PI of the 1914. So these are exciting trials. A lot of work has gone into these. We really need your help and support in this. So I would encourage everyone to ask whatever questions or raise any issues that you have. So with that, I'm going to turn it over to Sarah, who's our first speaker of the day.
Well, thanks so much, Roy. Thanks for inviting me to talk to this group and give the introduction to checkpoint inhibitors in lung cancer. Probably a topic that doesn't need all that much introduction. I think it's now become such a part of what we do every day as medical oncologists and radiation oncologists. I'm sure are learning more and more every day about how to incorporate immune therapy and deal with the toxicity that sometimes comes up. So I'm just going to give you a bit of an introduction just to lay some groundwork for the trials that you're going to be hearing about and really show you about the progress that we've made with immune therapy and lung cancer. So this is just an introduction slide to show you how the mortality from lung cancer has improved. And we all know that the incidence has improved and gone down in recent years, probably because of smoking, declines in smoking, but mortality has also decreased. And that is, I'm sure, for many different reasons. I guess as medical oncologists, we like to take some credit to, and our systemic therapies have improved survival. And this is a couple years old, this data, but the more recent update actually also continues to show an improvement in survival, I think, at least in part because of our systemic therapies that are improving outcomes, including immune therapy. Next slide. So this is a slide I borrowed from my colleague here at Yale, Roy Herbst, the other Roy, as you like to call him, or maybe that's Roy Decker. I'm not sure which is the other Roy these days. But so this is a slide taken from one of his review articles and a bit modified. And again, just shows the progress in non-small cell lung cancer. The different color boxes represent the different types of treatments or advances that have been made over the last 20 years or so. And you can see it really is just in the last couple of years in those blue boxes that we've seen progress in immune therapy, but it's been quick. So in about 2012 or so is when we first saw the benefit of nivolumab for patients who were refractory to other therapies in the first phase 1 studies. And just over the last 8 years or so, we've now basically made our way to using immune therapy in second line, where it was shown to be superior to docetaxel, and now first line, where it was shown to be superior to chemotherapy. And now, of course, we use it in different combinations, which I'm going to show you in a minute. And then now, I think probably even more exciting is we're starting to use it in earlier stage disease. So until the last couple of years, it was only used in advanced disease. Now you can see the rightmost blue box there is that we now use Durvalumab for stage 3 lung cancer because of the improvement in survival. And I think this, we'll have to have another update of this slide in a couple of years because there's so many ongoing trials, really hundreds and trials that are trying to advance the field even further. Next slide. So I'm just going to take you through some of the key trials that guide our therapy and show us how to use immune therapy in lung cancer. These are two of the first-line trials showing you the benefit of single-agent immune therapy compared to chemotherapy. On the left is the trial comparing pembrolizumab to chemotherapy for patients with high PD-L1. On the right is Atezo versus chemo, again with high PD-L1, and a clear survival benefit with the use of single-agent immune therapy versus chemotherapy for the high PD-L1 expressors. The Pembro trial specifically was updated recently to show that this benefit goes out several years, that patients are living longer and have an improvement in survival compared to chemotherapy. So I think a really amazing advance that we can use single-agent immune therapy for patients with advanced non-small cell lung cancer, at least for a subset of them with a high PD-L1 that are more likely to benefit. I'm not going to get into toxicity too much, although I'm happy to answer questions. Overall, toxicity is better. It's better tolerated than chemotherapy as well. Next slide. So I also wanted to show some combination data because this has really become commonplace now in patients with advanced non-small cell lung cancer that we're using combinations more and more. And this really is for the patients with the lower PD-L1 or zero PD-L1 expression. And so the top figures are showing you the survival benefit with combining pembrolizumab with chemotherapy, both for non-squams and squams. And then on the bottom is incorporating bevacizumab as well with chemo and immune therapy, in this case, atezolizumab. Again, all these trials are compared to chemotherapy as the comparator, and there's an improvement in survival. And this is really regardless of PD-L1 expression, which I think is really exciting. So even in patients with low or zero PD-L1 can have a benefit in survival when immune therapy is incorporated into their treatment. And next slide. Okay, and then this is really the last slide I'll show you about the treatment and how things have changed for advanced non-small cell lung cancer. So besides using single-agent immune therapy in some patients and chemoimmunotherapy, now we have some regimens that include combination immune therapy. We've been using this for several years in patients with melanoma, and now it's made its way into lung cancer. So this is Checkmate 227 trial using Ipi/Nivo, where, again, that was shown to be better than chemotherapy alone. And interestingly, this was in patients with PD-L1 greater than or equal to 1%, or on the bottom you can see less than 1%. There also was a benefit there of Ipi/Nivo versus chemotherapy. And then the 9LA study is basically put all the drugs we have all together, and that's Ipi/Nivo and chemotherapy. In this case, chemo was only used for 2 cycles, and Ipi/Nivo was continued. But the benefit is clear there as well, that compared to chemotherapy, there's an overall survival benefit. So now the trick really is how do we figure out which of these regimens is appropriate for which patient? I think if you go to the next slide, I kind of give you the overview of these different regimens. We look at histology. That's still important when we're choosing chemotherapy. PD-L1 expression, I think, is mostly important because you can see you have a lot of options for the greater than or equal to 50% group. It's important because you might be able to get away with single-agent immune therapy in those patients, especially. But there's so many other regimens combining different chemotherapies with immunotherapy, combining different immune therapies, that it really gives us this wealth of options, and we just need to continue to work on figuring out which one is better for which patient. But clearly a benefit with immune therapy in the first-line treatment of advanced non-small cell. Next slide. So moving to earlier stage disease, I think this is something we're all now very familiar with, which is the Pacific trial. This is looking at the benefit of Durvalumab as used as maintenance therapy after chemoradiation for unresectable stage 3 non-small cell lung cancer. A clear benefit in terms of progression-free and overall survival when Durvalumab is added. So, I think, again, this has become part of our standard treatment over the last few years, and now this is being refined further to try to improve on things in stage 3 disease, but they're part of our standard treatment in stage 3. Next slide. So in terms of early stage, I think this is very much still a work in progress. Many trials ongoing trying to incorporate immune therapy into early stage disease. This is data just from World Lung, just really last week, that shows the results from the neoadjuvant atezolizumab trial, where they used 2 cycles of atezolizumab for patients with early stage non-small cell lung cancer prior to resection. And that is just, I think, a beautiful waterfall plot showing the pathologic response. This isn't radiographic response here, but pathologic response showing that patients seem to really, for the most part, have some degree of pathologic response, and some of them actually had a complete path CR, about 7%, whereas 21% had a major pathologic response. So I think, again, really exciting times for early stage disease as well, where we're starting to incorporate immune therapy. Not yet standard, but I think with this really exciting data, hopefully on the horizon. And you can see the toxicity there as well, that we do see immune-related adverse events with atezolizumab, of course, but overall they were low grade, and patients were able to go on to their surgery successfully in the vast majority of cases. Next slide. I wanted to also just very briefly touch on small cell. I know you're going to be hearing about a small cell trial during this webinar. So small cell, of course, been a difficult disease to treat for so many years, and we've seen progress now in small cell lung cancer in the first-line setting with the addition of immune therapy again. In this case, you see two different trials. One is adding atezolizumab to standard chemotherapy, platinum etoposide, and on the right is the Caspian trial, which adds either Durvalumab, which is a PD-L1 inhibitor, or Durva plus Tremi, which is also a CTLA-4 inhibitor. In both cases, the addition of the PD-L1 inhibitor to chemo improves survival. The Tremi didn't seem to add much, so I don't think that's a regimen that's going forward. But now we have these two options for our patients with small cell lung cancer. And so, again, improving survival in a difficult disease to treat. So just wanted to summarize here and just show you this really is a new era for lung cancer treatments. Clearly, immune therapy improves survival for both non-small cell and small cell lung cancer in advanced stage disease. We're now using it also in stage 3 disease, where it also improves survival. I think there's really compelling data in early stage lung cancer, but those trials are still ongoing to make that part of our standard. And many ongoing studies are exploring immune therapy alone and in combination in all these different stages and histologies. So now I'm looking forward to hearing about the trials that we have and incorporating radiation and immune therapy into our treatment algorithms. Thanks.
So thanks so much, Sarah. So I think our first speaker here is Megan Daly to talk about the 1914.
Yeah, thanks, Roy, and thanks everybody for the opportunity to discuss S1914 on behalf of our study team. I do want to mention that Dr. Chuck Simone is also here on the call and is also available to answer questions as I will be. Next slide. And this is our full study team. Got a big team working on this study. So Sarah's already given us a wonderful overview of the role of immunotherapy in lung cancer, but just to come back to the specific rationale for immunotherapy in early stage lung cancer and the combination of radiation and immunotherapy in this setting. So as we all know, surgical lobectomy is the standard of care for fit patients with early stage resectable lung cancer, and adjuvant chemotherapy is indicated for certain high-risk factors and has been shown to modestly improve overall survival. Adjuvant immunotherapy is of interest to further improve outcomes and reduce toxicity profiles. And as Sarah just mentioned, now neoadjuvant atezolizumab in particular is particularly promising based on the World Lung data from last week. SBRT is a standard of care for medically inoperable early stage lung cancer and can achieve excellent local control, typically exceeding 90% at 3 years. But regional and distant failures do remain significant, particularly in patients with high-risk features. And adjuvant chemotherapy has not typically been used following SABR, both because of limited data and because the chemotherapy is not typically well tolerated in this frail, inoperable population who tend to have multiple medical comorbidities. So immunotherapy may have the potential to allow for fewer nodal and distant failures, and we hope will be well tolerated when given before, during, and after SBRT for early stage lung cancer. Next slide. There are significant potential benefits to combining radiation and immunotherapy. SBRT is less immunosuppressive than conventionally fractionated radiation or surgery, and specifically can even be immunostimulatory. Radiation can improve antigen presentation, can release high levels of tumor antigen, can upregulate immunogenic cell surface markers such as MHC1, and can induce immunogenic cell death. SBRT can increase homing of immune cells to the tumor microenvironment and can recruit regulatory T cells. It can shift tumor-associated macrophage polarization from M2 to M1 and can increase secretion of cytokines and upregulate cell surface expression of PD-L1. Next slide. This is just a schematic highlighting some of the radiation-induced immune changes in the tumor microenvironment following radiation. Next slide. In particular, when designing S1914, we spent considerable time thinking about the timing of immunotherapy and radiation in this study. And this is some unpublished figure from our translational co-chair, Dr. Artem Manjazev, showing work from his lab that demonstrated that in a murine model, when PD-L1 blockade was delivered prior to radiation, tumor control was significantly enhanced as compared to delivery of radiation followed by PD-L1 blockade. And this data and other data did help inform the design of our trial. Next slide. There's also interesting secondary analyses and other clinical data that suggest our study design may be reasonable. This is a secondary analysis of Keynote-1, which looked at pembrolizumab for stage 4 non-small cell lung cancer. This is a UCLA group that looked at the effect of prior radiation on response to Pembro. And the authors found that patients who had received radiation prior to subsequently receiving pembrolizumab had improved both progression-free and overall survival as compared to patients who had never received radiation, suggesting a synergistic effect. Next slide. There's also the Pembro-RT trial. This is a multi-centered randomized phase 2 trial that compared pembrolizumab alone to pembrolizumab with radiation. The overall response rate was approximately doubled with the addition of SBRT, with improvements of progression-free and overall survival that did not quite meet statistical significance, but nonetheless were quite provocative. There was also no increase in treatment-related toxicities with the combination. Next slide. There have been several early phase trials involving evaluating the combination of SABR with checkpoint blockade in early stage lung cancer, which have involved a variety of checkpoint inhibitors and different schemas in terms of the timing and duration of checkpoint blockade. We used the UC Davis phase 1 as a template for the design of our trial, which involved neoadjuvant concurrent and adjuvant atezolizumab for 6 cycles total, and that study should be published shortly. Next slide. This slide highlights the S1914 schema. Patients are randomized 1-to-1 between standard of care stereotactic radiation and stereotactic radiation in combination with neoadjuvant, concurrent, and consolidation atezolizumab for 6 months or 8 cycles total. Patients are stratified based on tumor location, size, and ZBROD performance status. Next slide. The hypothesis is that the addition of atezolizumab to standard SBRT in early stage medically inoperable lung cancer will improve overall survival and progression-free survival as compared to SBRT alone. Our primary objective is to compare overall survival between groups. The secondary objectives including progression-free survival, distant, local, regional, and local failure rates, frequency and severity of toxicities, and quality of life. Next slide. Inclusion criteria are relatively standard. Patients must have biopsy-proven lung cancer, biopsy-proven early-stage node-negative lung cancer. Some T3 patients are eligible with tumors up to 7 centimeters diameter. We unfortunately cannot enroll multifocal tumors or tumors with pericardial invasion. Patients must be medically or surgically inoperable or have documented unwillingness to undergo surgical resection, and they must have a performance status of 2 or better. Patients also must have at least one high-risk feature suggesting an elevated risk of regional or distant recurrence, including a tumor diameter of at least 2 centimeters or an SUV max of at least 6.2, or moderately or poorly differentiated or undifferentiated histology. Next slide. Exclusion criteria are also relatively standard. They can't have uncontrolled concomitant disease, significant cardiovascular disease, severe recent infections, history of severe autoimmune diseases, HIV, Hep B or Hep C, idiopathic pulmonary fibrosis, pneumonitis or organizing pneumonia, or have received recent systemic immunostimulatory or immunosuppressive agents. Next slide. This highlights some of the treatment details. We tried to be pragmatic with the use of SBRT in this study, and we allow a variety of fractionation schemas as long as they have a VED 10 of at least 100 gray. So these include regimens of 3, 4, or 5 fractions ranging from 50 to 60 gray total. Atezolizumab is delivered 1,200 milligrams IV every 21 days for up to 8 cycles for patients randomized to the experimental arm. Next slide. Our primary objective is overall survival. Assuming 10% ineligible or dropout, we need 432 eligible patients and should have 80% power to detect a hazard ratio of 0.7. Our secondary objective of progression-free survival, we should have 90% power to detect a hazard ratio of 0.65. We have 4 interim analyses planned. All analyses will evaluate early stopping for futility, and the third and fourth will also evaluate early stopping for efficacy based on overall survival. Our target accrual is 8 patients per month, which would lead to a 5-year accrual duration. Next slide. We have a number of laboratory correlatives planned as well, primarily based on on-treatment blood samples, as well as our archival tissue from the initial diagnosis. Next slide. There are currently two competing trials for the same patient population that are both industry-sponsored, Pacific-4 and Keynote-867. So we did want to highlight what we believe are some of the specific strengths of our study. We use a shorter total duration of immunotherapy, only 6 months, as compared to 12 to 24 months on the other currently accruing studies. We also do not require placebo infusions, which we believe should be appealing to patients. We also strongly believe that the timing and schedule of our study is based on a strong preclinical rationale, and now we have clinical data in the form of the recent World Lung data on neoadjuvant Atezo that also would support our current design. And finally, sites can gain accrual credit with cooperative groups when accruing to S1914. Next slide. So we would be delighted to answer any questions that any of you have about our study. We currently have enrolled a total of 11 patients, and we have 131 sites that have the trial IRB approved, with another 465 pending. And do we still have any time for questions?
Yeah, we do. Thanks, Megan. And I think we're just taking questions the old-fashioned way, verbally. Does anyone have the study open? Are we running into any barriers, or is there any reason people think they might not open the study? I'll just take a minute and echo what Megan said. I know that some of the other competing industry-sponsored studies have run into some accrual problems that are primarily based on the use of placebo and the long duration of treatment. So I think those are real advantages here. We're processing it through opening it ourselves right now, hopefully opening it any day now. I didn't think I was going to have to think of questions to ask you, Megan, but.
We have our contact information for the study team up here. If there are any specific eligibility requirements or study assessments that sites are finding particularly to be limiting, please do let us know as well. We're certainly open to considering select study amendments if they would significantly enhance accrual. So we're always happy to hear from people. Okay. Maybe you just did such a great job of convincing everybody that there are no questions. So we'll move on. I will echo that everyone here is available. PIs are desperately eager to get you to enroll to their trials. So if you have comments or questions or anything that's going to help you move to open it, please reach out to Megan. So our next speaker is Rod Al-Jamali. He's the PI of the 1933, and we have an assist from Tim Mitten, who's the radiation chair. So Rod, I'll turn it over to you.
Thank you, Roy. Yes, I'll present SWOG 1933. This is a pilot study of hypofractionated radiotherapy followed by atezolizumab consolidation in stage 2 or 3 non-small cell lung cancer patients with borderline performance status. Next slide, please. So there is no evidence-based data to guide treatment decision in patients with stage 3 non-small cell lung cancer with performance status 2 and stage 2 patients who are not candidate for standard of care surgical resection. And when we see these patients in clinic, many of these patients end up having either radiation, palliative radiation only, or radiation, sequential radiation followed by chemotherapy. Sometimes they get concurrent chemoradiotherapy with no data, with no safety or efficacy data in this particular patient population because they were excluded from all randomized phase 3 studies that set the standard of care concurrent chemoradiotherapy in stage 3 and surgical resection for stage 2. Basic science and clinical data support the synergistic activity of radiotherapy and immune checkpoint inhibitors, and we have good data for that synergistic activity. Hypofractionated radiotherapy was better tolerated and with similar efficacy in a similar patient population, a study done in UT Southwestern by Enger et al. That study was radiation only, basically randomized to standard fractionation versus hypofractionation arms with no immunotherapy. Immune checkpoint inhibitors were better tolerated than chemotherapy with less treatment-related adverse events in clinical trials and multiple clinical trials. Next slide, please. So compared to other solid tumors, high percentage of lung cancer patients present with performance status 2, largely because of comorbidities like COPD and heart disease. Now, we tend to overestimate performance status of our patients. This is a study looking at performance status as perceived by patients compared to as assigned by physicians. And in this study, 33% of patients thought that they had performance status 2, while physicians thought 21% of them had performance status 2. Generally, about a third of patients that we see in the clinic with non-small cell lung cancer present with performance status. So this is a good percentage of patients, and we, in that particular setting, in stage 2 and 3, we don't have evidence-based data to guide treatment decision. Next slide, please. So based on that, our hypothesis that hypofractionated radiotherapy followed by atezolizumab consolidation in patients with a stage 3 non-small cell lung cancer performance status 2, or stage 2 patients who are not candidates for standard of care surgical resection will be well tolerated and will lead to better outcomes compared to historic controls in this patient population. Next slide, please. So our primary objective is to evaluate the rate of grade 3 to 5 treatment-related adverse events in patients who are not candidate for surgery or concurrent chemoradiotherapy and have either performance status 0 to 2 in stage 2 or performance status 2 in stage 3 non-small cell lung cancer treated with hypofractionated radiotherapy followed by atezolizumab. Secondary objectives to evaluate response rate, progression-free survival, overall survival, and all grade treatment-related adverse events. Next slide, please. So inclusion criteria, so there's step 1 and step 2 registration. For step 1 registration is before radiotherapy, patients with stage 3 non-small cell lung cancer with performance status 2, or phase 2 patients who are not candidate for standard of care surgical resection. After they receive radiation for step 2 registration, for step 2 registration patients, they have to have received at least 45 gray of radiation and no evidence of disease progression on assessment scans. Key exclusion criteria: active autoimmune disease and history of interstitial lung disease or grade 3 or higher pneumonitis. Next slide, please. So this is the schema, as I mentioned. Stage 3 patients performance status 2 or stage 2 patients who are not surgical candidates. They get hypofractionated radiotherapy, 60 gray and 15 fractions, so 3 weeks, and then 2 to 5 weeks after completion of radiotherapy, they get a disease assessment with scans. And patients with no disease progression, they receive atezolizumab consolidation for up to 1 year. So no chemotherapy, hypofractionated radiation followed by consolidation immunotherapy with atezolizumab for up to 1 year. Next slide, please. So this is a pilot study with primary objective is to evaluate safety. So it's a small number of patients. So sample size 40 patients for safety analysis population. By the way, there is a plan to, if we prove safety in this study, to run a larger study with that approach compared to radiation followed by chemotherapy sequential. So the observation of 8 or fewer patients with toxicity, basically 20% of grade 3 or higher treatment-related adverse events will be considered as evidence to rule out 34% or greater toxicity rate calculated from historic controls. And estimating that 10% of patients registered to step 1 will not register to step 2 and 5% registered to step 2 will either not meet eligibility criteria or receive at least 1 dose of atezolizumab. Total target accrual is 47 patients. I think Tim has some slides to present as well.
I'll just add to that presentation. Next slide, please. I just want to show that there are a lot of patients in the United States who do not receive concurrent standard chemoradiation therapy for stage 2 or 3 non-small cell lung cancer. This was an unpublished analysis of National Cancer Database that shows that very, very few patients actually receive concurrent chemoradiation therapy if they're not surgical candidates. So even though these numbers may not be fully representative, and there may be some bias in accounting information in NCDB database, nevertheless, it paints a picture of many patients not being able to tolerate concurrent chemoradiation therapy. And the outcomes in these patients are obviously not as impressive as we see with concurrent chemoradiation followed by maintenance Durvalumab. Next slide, please. So the reason we chose the hypofractionation approach is based on the presented results of the UT Southwest randomized phase 3 trial, where 60 patients were randomized to either 60 gray in 30 fractions or 60 gray in 15 fractions. And the most important part was that there was no difference in toxicity. In fact, it appeared to be that the grade 3 toxicity was slightly lower in patients who were randomized to the hypofractionated arm. The outcomes were also very similar. Obviously, these are the patients who are not the most well performers, and therefore shrinking the duration of the radiation therapy is always a consideration in clinics. So for these patients, coming to our centers for 3 weeks is definitely more desirable than for 6 weeks. And as you've heard, there's also a thought and hypothesis that hypofractionated treatments may have a better interplay with immunotherapy. Next slide, please. So, in terms of the radiation therapy details, it's important to understand that the 4D treatment planning is required. This is an important consideration to make sure that this plan is safe and tolerable for patients. Only photons are allowed on this protocol, and the treatment is done with IMRT or VMAT planning techniques. RT must begin within 24 days after the registration, but simulation can take place before the registration. So sometimes some clinicians would want to make sure that the patient can tolerate simulation and that the initial planning looks favorable before registering the patient. But the treatment must begin with 3 weeks after the simulation. And then the IROC will perform a rapid review of each treatment plan, so please allow for 5 business days for each case to be reviewed. One of the motion controls techniques must be done if the tumor motion is greater than 1 centimeter based on the 4D CT simulation. Next slide, please. So in order for this treatment to be safe, the focus is on the organs at risk. So the delineation of the organs at risk with a margin is critical. And then you can see that the PTV 60, the 60 gray, goes to the volume that's created with subtraction of the organs at risk with expansion margins. And so then the organs, and then the target that receives the entire dose is the PTV 45. So with this treatment planning, we ascertain that the organs at risk are protected. Next slide, please. So this is the treatment planning protocol requirements. You can see that the doses are low, but again, this is with accounting for a subtraction of the organs at risk with a margin from the PTV60 region. And because there is some variation acceptable in terms of the coverage of the PTV60 and PTV45, with a good dosimetry and physics works, we believe it is absolutely possible to meet those constraints, at least as the acceptable variation constraints. Next slide, please. So again, if there's any questions, concerns, please reach out to any one of us, and we'd be happy to help you with patient accrual. Thank you.
Thanks, Rod and Tim. Do we have any questions from the audience at this point?
We do have a question in the chat box. It's from David Rabin. Curious as to your biological rationales for offering CIT after hypofractionated RT in this study as opposed to S1914.
So why are we doing, so Rod, do you want to answer that? Why are we doing sequential rather than concurrent?
Okay, why we're doing sequential, not concurrent. There are two things there. So originally, actually, when we designed that study, we submitted it to CTEP with concurrent followed by consolidation immunotherapy, but there was concern from CTEP about combining concurrent immune checkpoint inhibitor with hypofractionated radiation. After further discussion with CTEP, we decided to do it sequentially.
I think there were, as I recall, safety concerns about the hypofrac.
Hypofractionated with immune checkpoint inhibitor as concurrent, so we ended up doing it as sequential.
Yeah, I think in particular because this is a group of patients who, by definition, cannot really tolerate sequential chemo radiation. I think they considered it a relatively tenuous group.
Yeah, and I want to add one more point is that there is a study by Stephen Lin, MD Anderson, that's NRGL004 and performance status 0 to 1 and PDL1 more than 50%, doing radiation followed by immunotherapy. I mean, it doesn't compete with that study per se, but my point is that do we know that adding chemotherapy improves out? I mean, this is like general population, but here we are looking at a patient population that was excluded from all studies of concurrent chemoradiotherapy. We don't know the safety of concurrent chemoradiotherapy, and we have the option of potentially curative treatment option with less possibility of side effect, no chemotherapy, and we have the opportunity of having data on treating these patients on clinical trial and having data. This patient population was excluded from almost all bigger studies.
And just one more point is that in the UT Southwest randomized trial, out of 60 patients enrolled, 3 patients actually died from hypoxia that may have been related to the radiation therapy. There was no difference. In fact, there were 2 deaths in the conventional fractionated treatment, 60 in 30 fractions, 1 death in the 60 in 15 fractions. But nevertheless, we worry about toxicity of the thoracic radiation therapy in these patients with poor performance status, and therefore we all felt that it was safer to do it not concurrently but adjuvant setting.
There's another question in the chat from Jason Yee about if prior lung cancer is permitted, are there any requirements about distinguishing between a primary and a recurrence? And is it okay to do this in the recurrent setting? Would a patient with recurrent cancer be eligible?
Yeah, so yes, patients with recurrent cancer are eligible as long as the treatment from previous lung cancer has been more than a year. And
I'll ask one more question. So when we discussed this in our thoracic group, some of our medical oncologists wondered why these patients might not get, some kind of weekly chemotherapy or even sequential chemotherapy. And I know this question's come up over and over and over again in the time we were designing this trial. So you want to address that?
Yes, I think the most commonly used chemotherapy regimen and concurrent with radiation are either weekly carboplatin paclitaxel or cisplatin and etoposide. Day 1 cisplatin, day 1 and 8, and etoposide day 1 to 5, or platin alimta. Now, if you look at cisplatin, etoposide, and platin alimta from system, the systemic side effects from chemotherapy are substantial, with significant cytopenias and other comorbidities, mucositis. If you look at weekly carbotaxol, or although generally like the cytopenias and systemic side effects may not be significant, but there is significant pneumonitis. In fact, pneumonitis with carboplatin paclitaxel concurrent with radiation is more than other chemotherapy regimens. So if you add in pneumonitis to, in that patient population with performance status 2, with with COPD, their lung function is compromised to start with, those patients can get sick. So I think this study offers the opportunity of radiation only, no chemotherapy, less pneumonitis, and potentially curative.
Thanks, Rod. So we're going to move on in a second. One of the questions was about whether the presentations will be available to the participants, and I will ask our presenters if they are willing to share a version of their PowerPoint that we can disseminate afterwards, and hopefully Crystal can send that around. But in the interest of time, I think it's time to move on to Chad. Chad's going to talk about the 1827 Maverick study.
Thank you. So this is the SWOG S1827 so-called Maverick study, and this is a phase 3 randomized trial for patients with small cell lung cancer, both limited and extensive stage, with a randomization to a baseline of MRI brain surveillance plus or minus PCI. And I've had the privilege of working on this with a great team, as you see here. Next slide. So everyone knows about PCI, but just for some brief background on where we're at and why we're running this study. So PCI has historically been used in the treatment of small cell lung cancer because there was a realization that this disease had a very high proclivity for subsequent CNS spread and brain metastases. And so trials were done starting in the 1970s looking at prophylactic cranial irradiation to try to mitigate that risk. And these trials were associated with a decrease in brain metastases, but they also started to see, over time, an increase in neurologic toxicity. And the impact on overall survival was debated. That was, of course, until 2 landmark studies were published, the first in 1999 and then the second in 2007, both in the New England Journal of Medicine. The first was a meta-analysis that looked at primarily limited stage patients getting observation primarily without CNS surveillance, plus or minus PCI. And the second was a randomized trial dedicated to patients with extensive stage disease, looking at observation versus PCI. And both these studies were limited by heterogeneous or often absent brain staging and surveillance, but they showed an overall survival benefit, and this helped get PCI into the guidelines as a standard of care for both limited and extensive stage disease. There was a subsequent, more modern randomized trial that was carried out in Japan, a multicenter study that tried to address some of the limitations of the earlier PCI data. And in this study, brain MRI staging and surveillance were both mandated in both arms, and then they randomized patients to plus or minus PCI. And in the context of brain MRI staging and surveillance, there was no difference in progression-free or overall survival with the addition of PCI. And in fact, PCI was associated with a trend towards inferior survival, but this was not statistically significant. So what are the implications of this conflicting data? Well, the Japanese study suggests that in the context of MRI surveillance, allowing for early salvage therapy when brain metastases occur, that we might be able to avoid the toxicity of PCI and we might not need to deliver radiation to the entire brain in all small cell lung cancer patients. In response to this data, the NCCN now recognizes PCI as optional for extensive stage, because that was the population studied in the Japanese trial, and recommends MRI surveillance for all patients regardless of PCI delivery. And here at the bottom, I just have the two Kaplan-Meier curves from the EORTC and the Japanese trial in extensive stage disease. On the left, we have a survival benefit in the EORTC trial with PCI compared to brain imaging that was only done for symptoms, not surveillance. And then on the right, we have the Japanese trial, which had MRI surveillance for all patients. And in that context, there was no benefit to PCI in terms of overall survival. Next slide. So here's just a look at the contemporary NCCN guidelines. And on the top, we have limited stage disease. And you can see there in green that prophylactic cranial radiation remains a Category 1 for limited stage small cell lung cancer. And the reason for that is that the Oprin meta-analysis from 1999 remains the best data on this topic. The Japanese trial did not include limited stage patients. And then on the bottom in red, we have extensive stage disease, where PCI remains a reasonable consideration according to the NCCN. And the reason for that is that we now have conflicting data from the EORTC trial and the Japanese trial, one study showing a survival benefit and one study showing no difference. And then on the right, we have, in purple, we have the recommendation that MRI surveillance of the brain should be done in all patients regardless of PCI delivery. Next slide. And so why does this matter? Well, as we know, therapies like whole brain radiation and PCI are associated with neurocognitive toxicity. And so here I just have two studies. On the left, we have a pooled analysis of two RTOG studies that looked at both small cell and non-small cell patients receiving PCI. And what they found was that PCI was associated with both tested and patient-reported neurocognitive toxicity at both 6 and 12 months. And on the right, we have a rather recent randomized trial. This was actually done in patients with non-small cell lung cancer by the Dutch group, and we can see that PCI is associated with neurocognitive toxicity both early and throughout the follow-up on this trial. Next slide. So in terms of the oncology community and where we're at in terms of PCI for small cells, so as I showed on one of the previous slides, PCI remains a Category 1 recommendation for limited stage disease, but still approximately 40% of patients with limited stage disease don't receive PCI. There have been a number of patterns of care analyses that have demonstrated this, and the primary reason for withholding PCI has to do with concerns for cognitive toxicity from both providers and patients. There was a 2019 survey that looked at almost 500 radiation oncologists, primarily asking the question about the use of PCI in extensive stage disease. And what was interesting is they asked the respondents about their use of PCI both before and after the Japanese trial, looking at MRI surveillance plus or minus PCI in extensive stage. But what they found was that there was widespread recommendations for PCI in extensive stage disease before the Japanese trial, 72% recommending it before, and then that number dropped to 44% after the publication of the Japanese trial. But you can look at this both ways. I mean, that's a significant drop in the recommendations for extensive stage disease. But still, almost 50% of radiation oncologists do recommend PCI for extensive stage disease in the modern era. The survey also asked about willingness to enroll patients on a trial of MRI surveillance plus or minus PCI, and 82% said that they would enroll patients on such a trial. And we also sent out separate surveys to SWOG and Alliance members, and there was a pretty strong equipoise indicating a desire to look at this question in both limited and extensive stage patients to answer this question hopefully once and for all. Next slide. And so that leads us to our trial schema. So again, this is the acronym for this study is the MAVERICK study, SWOG S1827. And this is a study of brain MRI surveillance plus or minus PCI. And on the left, you can see the general inclusion criteria, and I would just highlight that this study is open to patients with both limited and extensive disease. And the inclusion is for patients who have had no brain metastases either at diagnosis as well as after first-line therapy. And first-line therapy is a pretty open proposition for this trial. We tried to make it a pragmatic design that welcomes any and all generally accepted first-line approaches for small cell that are acknowledged by the NCCN guidelines. So patients with limited stage, obviously most of these patients are going to be getting chemo radiation, but in extensive stage there's starting to be a number of treatment options, including chemotherapy, chemoimmunotherapy, as well as chemoimmunotherapy plus or minus thoracic radiation. And so all of those approaches are acceptable, and patients can go on the study having had those. And then the randomization here is to brain MRI surveillance plus or minus PCI, so a pretty straightforward randomization. Our stratification will be by limited and extensive stage, the use of upfront immunotherapy as well as performance status. And then the brain MRI schedule is shown here at the bottom. Similar to the Japanese study, we're getting brain MRIs Q3 months for year 1 and Q6 months for year 2. And that's consistent with the NCCN guidelines, so that shouldn't be an issue for any payers, and so far it hasn't been. Hippocampal avoidance, PCI, is allowed on this study. That is an acknowledged treatment option per the NCCN guidelines. And so while there's not data, phase 3 data that's established that that's beneficial in this population yet, it is considered a standard option, and so that's allowed, and it's something that we're tracking for planned subset analyses. And hippocampal avoidance whole brain, when patients develop brain metastases, is also allowed. Radiation therapy is recommended at the time of brain metastases, and that's up to physician discretion, and we do allow SRS. And then to the right, we just list the primary and secondary endpoints. So the primary endpoint of this study is overall survival. And this study is designed as a non-inferiority study because truly our hypothesis is that in the context of close MRI surveillance, we think that we will have an opportunity to salvage brain metastases in the absence of PCI, and that there would be no survival penalty for close surveillance. And so the hypothesis is that there will be non-inferior survival with MRI surveillance alone. And then we list our secondary and exploratory endpoints here, and it's as a non-inferiority study, we have a large accrual goal of 600 analyzable patients. The study is currently open at almost 200 centers, and we have about 400 centers that are still pending, and our accrual currently is at 27 patients. So we would really encourage you that if you're interested in the study to please open it at your center to help us answer this important question. Next slide. So a few notes. This study is open across the NCI cooperative groups, SWOG, NRG Alliance, ECOG, also in Canada and the CCTG, and it's specifically championed in the VA system, and we're really trying to encourage VA participation and enrollment. Community site participation is also a priority. Several comparable successful brain radiation trials have been run in the NRG, both CC001 and 003, which have looked at the question of whole brain and PCI plus or minus hippocampal avoidance. Each of these studies have exceeded their projected accrual rates, and the NCORP system has been a very big part of that, accounting for 20 to 30% of their accrual. And so if you're from a community center, we're so glad that you're considering this trial, and thank you for participating in it and putting patients on. We really do need your help. As I mentioned before, it's a pragmatic design, and we really tried to maximize the idea of low barriers to accrual. This study allows immunotherapy, hippocampal avoidance, salvage radiosurgery, consolidative radiation for extensive stage. And if you have any questions about enrollment, please feel free to reach out to me, and I'm happy to answer any questions you have about eligibility. Cognitive testing, so this can be a perceived barrier if your site hasn't participated in that before. I'd just like to highlight that this is really supposed to be a straightforward thing. We have the same test and the same neurocognitive chair, Dr. Jeffrey Weffel from MD Anderson, who's helped lead a number of NRG trials, including the recently completed and ongoing CC001 and 003 studies. So if your center participated in those trials, you're already likely very familiar with this practice. And there are financial site incentives that are provided for completion of these tests to help make that more palatable. Accrual is really the key, and so when we're thinking about offering this and discussing this with patients, it's really important to keep in mind in our framing that the PCI really is the historic standard of care, and it remains a Category 1 recommendation for limited stage patients and a standard treatment option for extensive stage where we have conflicting randomized data. And so, we try to present this study as a way to safely de-escalate therapy and hopefully decrease toxicity for our patients, where we really want to do that on a phase 3 randomized study with close surveillance and tracking these outcomes so that we can hopefully improve outcomes for future patients. And so, next slide. Thank you so much for listening to this presentation. And here we have the original Maverick encouraging you to open this trial at your center. And so please, if you have any questions at all, please feel free to reach out to me. This is my email. I'm happy to look at bringing this trial to your center and answer any questions that you may have.
Chad, there's one question in the chat to clarify. The Maverick allows co-enrollment on other small cell trials, but there are some trials that do not allow co-enrollment on Maverick, and one of them that is probably common in this group is the LU-005. Is that correct?
Yeah, that's correct. So for those who are not familiar, LU-005 is a great study that's being run through the NRG. It's specifically limited stage small cell lung cancer looking at chemo radiation plus or minus atezolizumab. And that study was launched prior to Maverick, and so we did have some conversations around trying to allow dual enrollment on those studies, and ultimately the NRG felt that wasn't feasible. LU-005 recommends PCI for their patients, and there was concern about adding another variable into their study. So ultimately we weren't able to make that work. I would just say a couple things about that. So I know that's a very important study. We actually have both of those studies open at my center, and I really do support the LU-005 study. Important to keep in mind, one, the LU-005 is specific to limited stage small cell lung cancer, whereas Maverick allows both limited and extensive stage, so no overlap with the extensive stage patients. And the other thing I would say is the way that we look at it here is, LU-005 is a great study that's offering enrollment at diagnosis. So you have patients who are coming through the door with a new diagnosis who might be interested in going on that study and getting access to atezolizumab. And that's a great thing. But we also know with small cell lung cancer that a lot of patients don't end up going on first-line studies for a variety of reasons. Sometimes patient preference, but also sometimes we are starting therapy rather urgently, or maybe a patient's gotten their first cycle or two of chemotherapy at an outside center before coming to our center. So not every patient can go on LU-005, and so the Maverick study enrolls after first-line therapy. And so it's a nice study to have there to catch all of those patients who might not have gone on a study at diagnosis. Maverick is still, there waiting for them to be offered after they've completed first-line therapy. So hopefully these studies will end up being complementary in your portfolios, and that's how we look at it here at our center as well.
So thanks, Chad, and thanks to all of our speakers, Sarah and Megan and Rod and Tim. So I would encourage all of you to open these studies. If you have reservations, questions, concerns, please reach out to the PIs, reach out to me. We're more than happy to spend the time talking you into it. So with that, thanks everybody very much, and we look forward to seeing you at the next SWOG meeting.